Okay, great. Good morning, everyone. My name is Danee. I'm one of the Chief Cardiology Fellows this year. I am here with Dr. Kelly Smith, who is a professor in the Department of Pathology and also the Division of Nephrology, and also the Director of the Cardiovascular and Renal Pathology Services. We're excited today to bring you this year's first cardiac pathology grand rounds. The outline for today's talk, we're going to go through 3 different patient cases. I'll start with a case presentation, and then Dr. Smith will share what the pathology findings showed. I'll end with a few teaching points about each of the case and a quick update on how the patients are currently doing. In the interest of time, we might ask that you keep questions until the end, in which case we're happy to answer questions about any of the cases. To jump into the first case, this is Can you hear me now? Yep. Okay. So the first case is a 28-year-old man who presents with chest pain. He was previously healthy, but comes in reporting 2 days of sharp chest pain that's worse with lying supine. He reports over the same time period a dry cough and subjective fever. He doesn't have any recent travel or known sick contacts, no medications or supplements, and he received his second COVID vaccine about 1 month prior. His exam was fairly unremarkable. It was just notable for a tachycardia to the 120s. His basic metabolic panel was normal. His CBC showed that he had a mild leukocytosis to 13. The diff showed that there was neutrophilic predominance, but that he also had significantly elevated eosinophils. He also had an elevated troponin to 6.4, a BNP of 435, an elevated CRP of 48, and of note, his COVID test was negative. This is what his EKG looked like. It confirmed that he was in sinus tach going at about 130. You can see that throughout the inferior leads and many of the precordial leads that he has kind of diffuse ST elevations, but without reciprocal changes. We next get an echo, and I'm going to play the images here. You can see that the left ventricle is normal in size, but that there's pretty severely reduced systolic function, in addition to a moderate-sized pericardial effusion that on echo had evidence of increased intrapericardial pressure. As a result of all of these findings, he's next taken to the cath lab where they perform coronary angiography that reveals normal coronary arteries. He also has the effusion tapped, and they're able to drain 270 cc's of serous fluid, and he's subsequently admitted to the CCU. At this point, just think to yourself sort of what is currently at the top of your differential. Do you think that this is viral myocarditis, eosinophilic myocarditis, a stress cardiomyopathy, or coronary vasospasm? And then I'll turn things over to Dr. Smith.
Okay, thank you, Danee. So the patient got a biopsy to see what was going on in the heart. And this is a low power view of the heart biopsy. You can see it really doesn't look too bad. We have 5 pieces of endomyocardium. And for the most part, we're just seeing a lot of this pink muscle. So that looks pretty good. But if you look, squint and you look, there's a little bit of blue stuff in the interstitium in at least a couple of these pieces. And then at higher power, we can see this piece is relatively spared without much interstitial inflammation or any abnormalities. But this piece over here actually has quite a bit of interstitial inflammation that's sort of tracking through all of the spaces in between the cardiomyocytes. Now, at higher magnification, we can get an appreciation that there's some expansion of the interstitium. Maybe some of this inflammation is encroaching upon the cardiomyocytes, and we keep going higher and higher. And we see, yes, there's actually quite a few inflammatory cells. We're starting to get a hint that there might be a little bit of pink or eosinophilic granular material as well within this inflammation. And in some areas, there's quite marked expansion of the interstitium, as well as some abnormalities within some of the cardiomyocytes. Here's the highest power magnification I'll show you. And you can see here's some, scalloping of the cardiomyocytes, a little bit of abnormal cytoplasmic structure, maybe some evolving myocyte injury or necrosis, and then a lot of inflammatory cells. And this is a mixture of cells. There's lymphocytes, there's macrophages, but there's also eosinophils present. And, down here, you might be able to see one, true bona fide eosinophil, but there's a lot of eosinophil dust all throughout this material here. And so there's been a lot of eosinophil degranulation that's present throughout the interstitium. So there's a prominent influx of eosinophils as well as some macrophages and lymphocytes. And that has the histologic features then of myocarditis. So if you look at the Dallas criteria, you basically want to see interstitial inflammation and evidence of some cardiomyocyte injury. And so we have both of those here. And then if you want to go further, you can then try to give it a type or a distinction. And you say, well, is it mostly lymphocytes? Is it mostly eosinophils? Is it granulomatous? Are there giant cells present? Neutrophils, mixed, whatever. So here we have one that's really notable for the presence of eosinophils. And so we're going to label this as an eosinophilic myocarditis. And clearly then the question is, well, what's causing this? Is this associated with some sort of an allergic reaction? Does it have something to do with this patient's vaccine? So what about eosinophilic myocarditis? What's our experience here at University of Washington? So I went back and looked, from 2000, and it's rare. So we see a case like every one case every 4 to 5 years. So it's not really something that we see very common. When we see it, we get excited because it's unusual. Well, in 2021, we had this bump. We had 5 cases, which for us, that's an epidemic in eosinophilic myocarditis. And so what are these cases that we see? And a lot of them are sort of what you expect. There's some with an allergic type reaction, DRESS syndrome, hypereosinophilic syndrome, Churg-Strauss. But if you look at the 5 cases in 2021, 4 out of the 5 were 1 to 4 weeks past COVID-19 mRNA vaccine. So, there's I think a question of whether or not this is related to the vaccine. I think the timing, especially in this instance, is a little bit long for most people to swallow it, but it is a fairly striking coincidence, I think. Okay.
Thank you, Dr. Smith. Okay, so just a few more points about eosinophilic myocarditis. I think that when you have suspected eosinophilic myocarditis or biopsy-proven eosinophilic myocarditis, it's helpful to think about what might be causing this. I think Dr. Smith alluded to a few causes. I think of it in generally 3 different categories. The first category being reactive causes. So hypersensitivity reactions or DRESS syndrome is very common. Infections, classically parasites, and then certain autoimmune conditions, Churg-Strauss or now renamed EGPA, are common culprits for eosinophilic myocarditis. The second bucket include kind of more primary causes of hypereosinophilia, so things like clonal neoplasms, certain types of leukemias and lymphomas. And then lastly, really this idiopathic hypereosinophilic syndrome, which is truly a diagnosis of exclusion. For our patient, he underwent a very broad workup for all of these different causes. We consulted infectious disease, rheumatology, oncology, and effectively were able to rule out many of these causes. And at the end, we're left with this either being post-vaccine myocarditis versus idiopathic hypereosinophilic syndrome. As Dr. Smith mentioned, I think that most patients who have reported post-vaccine myocarditis are presenting within the first week after. This is data from after the second vaccine dose, as was with our patient. But you can see that there are still kind of a spread of patients who present in the weeks following vaccine. And this would be kind of where our patient was presenting. And so maybe less likely, but not impossible that this was related to the COVID vaccine. I think from the news, we know that the highest risk patients for developing post-vaccine myocarditis are young adolescent males. I think this slide is to demonstrate that, the CDC still recommends getting vaccination in all indicated age groups. And I thought that this data was interesting in that even in the highest risk group for myocarditis post-vaccine, you can see that their risk of developing myocarditis is still on the order of 6 times lower when compared to a COVID-19 infection. Fortunately as well, post-vaccine myocarditis, the clinical course is typically very mild. This was a retrospective study that looked at 140 patients who were less than age 21, who were presenting with chest pain and diagnosed with presumed vaccine-related myocarditis. You can see that about 80% of patients present with a completely normal ejection fraction, 16% present with a mildly reduced ejection fraction, so between 45 and 54%, and then only a very, very small proportion of these patients present with moderate or severe dysfunction. These patients were hospitalized on average for 2 days. Only 2 patients required inotropic support, and actually all of the patients who presented with reduced ejection fraction at presentation all had normalized ejection fraction at follow-up within the short term, so about 1 month. Then on the right is just some data out of Hong Kong. This is looking at all the patients who were hospitalized with myocarditis, and they sort of stratified patients based on whether or not they concurrently had a COVID-19 infection versus if they had high suspicion that this was related to the vaccine. And you can see that this also demonstrates kind of the more benign course of post-vaccine myocarditis. And you can see that there are much lower rates of heart failure, progression to dilated cardiomyopathy, and mortality at 6 months. So what do we tell our patients? I think this is something that's going to come up in all of our clinics at some point, where someone's asking you for guidance on if they should get further COVID vaccinations. The CDC currently gives some guidance about this, but I think a lot of it is based on limited data. Typically, they recommend that if you feel fairly confident that someone had myocarditis and it's related to the vaccine, that you should be deferring future COVID-19 vaccinations. However, if there's maybe a little bit more uncertainty in the correlation of the vaccine with the onset of myocarditis, so say myocarditis that develops before vaccination or greater than 3 weeks after, the CDC says that it is probably okay to receive another vaccine. This is, of course, weighed against, doing a risk-benefit analysis for each individual patient and trying to decide what would be in their best interest. This is from the CDC website, and I apologize, the text is a little bit small, but just to know that if you just Google CDC, like interim data on COVID vaccination, there is a part of their website that has these recommendations that I just mentioned. And in the red box, they're just saying to consider how at risk is this patient of deteriorating from a COVID-19 infection, weighed against how severe was their presentation of myocarditis. So to conclude this first case, this 28-year-old man who came in with biopsy-proven eosinophilic myocarditis ended up doing very well. His EF normalized rapidly by day 4 prior to him being discharged. He was treated with prednisone, and you can see the graph on the right shows that after prednisone was started, his eosinophils basically melted away. And rheumatology as an outpatient helped slowly wean his prednisone over the next year. And you can see that based on his eosinophilic count, he remained in remission. He was also closely monitored for any recurrent heart failure. He had a couple subsequent echoes that showed completely normal function. And this case was back from 2021, but at that time he was advised to avoid any future COVID vaccinations, I think just based on the severity of his initial presentation. Excellent. So we'll just jump into, we have a question.
Yeah, Danny, kind of interesting case. Can you comment about, I haven't taken care of a patient like this in a long time, but is new data that steroids play a role in this? I'm surprised to see that.
Oh, I should clarify that. Thank you. So I think that in the reports that I've seen, I think people are treating post-vaccine myocarditis in different ways. I think anti-inflammatory, so NSAIDs are actually the most common, but there's a handful, maybe 20% of patients who are treated with steroids. I think the reason why he was treated with such high dose steroids and for such a long time was because they couldn't rule out that this wasn't idiopathic hypereosinophilic syndrome. And so he really was on steroids, I think, upfront for both conditions, but then rheumatology kept him on a longer course for the possibility that this was hypereosinophilic syndrome. Yeah, so there's guidelines about when to proceed to endomyocardial biopsy. I think if you have fulminant myocarditis or unstable ventricular arrhythmias, typically those patients will bypass a cardiac MRI and they'll go straight to biopsy. In the interest of time, I didn't include all of the studies, but he did get a cardiac MRI that looked consistent with myocarditis. That was actually performed after he got his biopsy showing eosinophilic myocarditis. And I think it was in part due to the fact that this case was from 2 years ago. I don't think we had as much data as we do now. And I think given his presentation with concern for tamponade and the severe LV dysfunction, I think people were very nervous about how he was going to do and if he was going to subsequently develop fulminant myocarditis. So he didn't quite meet the qualifications, like he was hemodynamically stable, but I think that's what pushed the team early on to send him to biopsy. I think in the guidelines, it's also a 2A recommendation to consider going to biopsy after cardiac MRI if you have concern for allergic reaction or peripheral eosinophilia. So I think you could have still made the argument that he would have gotten a biopsy anyway. And in this setting, I think rheumatology used the definitive diagnosis to kind of justify his really long course of steroids. So I don't necessarily disagree, I guess, with the management that was done, but I think in today's era, we would probably do a cardiac MRI first and then decide whether or not we want to proceed with biopsy. Okay, to start our second case, this is a 71-year-old man with MGUS and a new diagnosis of atrial fibrillation, for which he's referred to cardiology. This workup is actually done outside of our system. So he's seeing cardiology for AFib. As a result, he gets an EKG and an echo. The EKG shows low voltages. His echo is only notable for moderate LVH, and this raises concern for the possibility of cardiac amyloid, given his history of MGUS. He next gets a cardiac MRI, and this apparently showed diffuse LGE consistent with an infiltrative process. And so he was next referred for an endomyocardial biopsy that was nonspecific with just fibrosis and myocyte hypertrophy. However, there was no evidence of amyloid, granulomatous inflammation that would be consistent with sarcoid or iron deposits. He next underwent a bone marrow biopsy, and this was negative for progression to multiple myeloma. And so he was next referred for an FDG PET. This was his initial PET. I've just highlighted the images that show inflammation. You can see in the basal anteroseptum, he has a small area of moderate inflammation. He started on prednisone under a presumed diagnosis of isolated cardiac sarcoidosis, even though from the notes, I don't think he had reduced ejection fraction or arrhythmia. Either way, he started on prednisone, and his subsequent PET shows that the inflammation has resolved. They try to taper steroids, and on repeat imaging, the inflammation has now come back, this time in a slightly different distribution in the anterior and anterolateral wall. They increase his steroids and repeat another PET, and you can see that there is still persistent inflammation seen in this same territory. So at this point, this patient is referred to UW for either refractory cardiac sarcoidosis or diagnostic uncertainty. So when he presents to the University of Washington, we find out that his MGUS has recently progressed now to smoldering lambda myeloma. Oncology plans to initiate him on treatment that's actually used for multiple myeloma, given that they're concerned that he was very high risk for further progression. Medications he's on included prednisone, lisinopril, carvedilol, spironolactone, apixaban, and atorvastatin. This is his echo at UW. You can see that he does have evidence of LVH in addition to low normal systolic function, and he has a global longitudinal strain pattern that perhaps shows some apical sparing. So at this point, what's the highest thing on your differential? Is this isolated cardiac sarcoidosis, as was thought by his outside cardiologist? Do you think that this is AL cardiac amyloidosis, ATTR cardiac amyloidosis, or chronic myocarditis? And the answer is he got a biopsy.
No one wants to put their money on the table. Any guesses from the audience? AL amyloid. Okay, we got an AL amyloid. All right. Anyone else? Second. Okay, so we have an overwhelming audience support for the diagnosis of AL amyloidosis. Okay, so here's the cardiac biopsy, some decent pieces of myocardium. And for the most part, these look like just big pieces of muscle without a lot going on. So if we're looking for inflammation, sarcoidosis, we're not seeing it, okay? However, there is this little area here of pink stuff. And so what's that? We hone in at higher magnification, we see, oh, there's this pink material that's infiltrating and replacing some of the myocardium here. That's suspicious. At higher magnification, we see this pink amorphous material, looks a lot like amyloid. A trichome stain shows the tinctorial properties of it, where it has this sort of purplish appearance, and that's also characteristic of amyloid. And then we move on to the diagnostic stain, where we do a Congo red, and we say, oh, well, look at this stuff here, it's congophilic. And when we do the polarization, we see this nice apple green birefringence. So we see, looks like amyloid. So we have the diagnosis of amyloidosis. Now what do we need to do? We need to type it. And so we're going to type that by mass spectrometry. And so if everyone doesn't know, if you're going to type amyloid, you should do it by mass spectrometry. There's still places that will do it by immunohistochemistry, but there's a significant amount of false positives and false negatives, making that test just completely unreliable. And although it might get it right sometimes, you will make mistakes that could be costly. So Mayo initiated this protocol. We actually developed our own test in-house where we do a manual microdissection. We'll take slides, we'll dissect out the areas with amyloid, we'll then process the tissue, and then we'll subject that to tandem mass spectrometry. The data then from the mass spec, both the MS and the MS data, will be put through a pipeline that was put together by Bill Noble to actually give us the results. In the end, what we do is we get these normalized spectral abundance factors for each of the proteins. We use that to have a semi-quantitative analysis of what proteins are present in all the samples, and then use that to determine the type of amyloid. And this is just an example of some of the common forms of amyloidosis. So serum amyloid protein A, that was discovered here at University of Washington. And transthyretin and LEC2, and we can see that our test is essentially, it's a near perfect test, 100% sensitivity and specificity when we do it. And, developing this is really, it takes a village to do this. So this is a project that I started years ago with Mike McCoss in Genome Sciences. And then, Bill Noble is essential to have the informatics support. And then Bill Phipps, and Andy Hoofnagel helped take it across the finish line here and develop it into a clinical test, which is a whole different level of sophistication compared to just a research type of operation. So this are the results. Should have put your money on the table, huh? You would have lost. Okay, so we are only detecting essentially transthyretin, and if you look at all the amyloidogenic proteins here, so this patient has transthyretin amyloidosis. So interpretation, ATTR type amyloidosis. Here was a paper that I came across that actually showed that showed 5 patients that have at least the PET scan data that's very similar to ours. So this was 5 patients. They have cardiac PET CT because they thought that they were suspicious for cardiac sarcoidosis. They did see positive uptake in the myocardium as this patient. And then they had endomyocardial biopsies that showed ATTR type amyloidosis. And so, in the paper, they speculate that there might be an inflammatory component to ATTR amyloidosis to explain this. Why do you get a positive FDG uptake in the PET CT? As you saw in that biopsy, and as I've seen in many cases, there's not a lot of inflammation there. So I don't really have a great explanation for why you get the FDG uptake. And if anyone here has some speculation or some, hypothesis for what that is, I'd love to hear that. Later, let's wait till Danee finishes up. So, also, if you think someone has amyloid in the heart, you always should think of ATTR. So this is from Mayo. They looked at, from the cases that they've typed by mass spec, they have over 5,000 cases, and roughly 2/3 of the cases are ATTR, and then 1/3 is AL, and then 1% is some of these other weirdos. But even with an MGUS or a kappa lambda ratio, there's some work by Mark Holushka at Johns Hopkins, who said, well, you can use the kappa lambda ratio to sort of bias it. If it falls between this range of 0.5 to 5, it's probably it's non-amyloid. If it's outside of that range, it's non-primary amyloid. If it's outside of that range, it's primary. It's AL amyloid. Well, our patient had 6.4, so it's outside of that range. Based on those criteria, it should be AL amyloid. Well, this is ATTR, and this is one example of many. And so we've had several examples run through our lab where we have patients that have what is clinically thought to be a primary amyloidosis, and then it's either a bone marrow biopsy or a heart biopsy that shows, lo and behold, they actually have ATTR. So if you are in doubt, which you should be most of the time, get it typed, and get it typed by mass spectrometry.
All right, thank you very much. Okay, so I just want to talk briefly about ATTR cardiac amyloidosis. I think this is a growing problem for multiple reasons. You can see the graph on the left shows that the number of diagnoses of both ATTR wild type and variant amyloidosis is significantly increasing over the years. I think this is due in part to the increased recognition that ATTR amyloid is actually quite common. There's a few very provocative studies that are retrospective that looked at patients. The first study is looking at patients, octogenarians who died with heart failure, and at autopsy, over 20% of them had ATTR amyloid deposits in the heart. The second study was looking at patients who were referred for TAVI, for severe degenerative aortic stenosis, and they went through PYP scanning, and up to 16% of those patients had ATTR amyloid. I think we're also seeing more of it because our population is aging, and we know that ATTR amyloidosis, previously referred to as senile ATTR, is commonly seen, or the risk increases with age. We also have improved diagnostic tests. So to diagnose ATTR amyloid, you no longer need to have a biopsy. You can do a special nuclear scan called a technetium pyrophosphate scan that can definitively diagnose ATTR amyloid. In addition, in 2019, the US FDA approved tafamidis, which is the first treatment for ATTR cardiac amyloid. So I think people are now much more motivated to go looking for it now that there's something that we can do about it. Just really briefly, things to look out for when you're talking to patients in clinic and when the alarm bells should go off. I think if you have an older patient with heart failure and you're not quite sure the etiology, particularly a lot of our HFpEF patients, AFib, super common thing that we see, bradycardia and conduction abnormalities. I think the very common testable associations that you might hear of are carpal tunnel, particularly when it's bilateral, and then also lumbar spinal stenosis. And then don't forget about peripheral neuropathies, and then the presence of orthostatic hypotension that actually makes this really hard to treat with a lot of our cardiac drugs. Things like ACE inhibitors and beta blockers classically are not well tolerated in this population due to the prevalence of autonomic dysfunction. Classic echo findings include things like ventricular hypertrophy, biatrial enlargement, the global longitudinal strain pattern that sort of spares the apex, and then a restrictive diastolic filling pattern. When you suspect that a patient might have cardiac amyloidosis, the first part of the workup is to send serum-free light chains and immunofixation. I think if this is positive, this warrants a hematology consult and consideration of biopsy of the affected tissue. In the past, it's been thought that we could biopsy the fat pad, but I think now we sort of go after the organs that you think are involved. And if you confirm the presence of AL amyloidosis on pathology, then you have your diagnosis. If, on the other hand, the initial workup is negative, then you might have a higher suspicion for ATTR amyloid, and you'll go down the other arm of the pathway, which really is the next step is to get this technetium-99 PYP scan. This was classically like a bone scintigraphy study that they just noticed that for whatever reason, technetium is taken up into amyloid deposits. And so this is a way to definitively diagnose ATTR amyloidosis. As with our patient, though, some patients may still arrive at this diagnosis via biopsy. If there's any sort of diagnostic uncertainty about what's going on, patients often receive endomyocardial biopsies for that reason. And so you may arrive at this diagnosis through a biopsy as well. This was the landmark paper, the ATTR ACT study, that really demonstrated that tafamidis has overall mortality benefit. You can see that the curves start to deviate around 15 months. In addition, patients who were on tafamidis had a slower decrement over time in their 6-minute walk test and quality of life scores. It's generally thought that patients who have a life expectancy greater than 1 year should be considered for tafamidis for this mortality benefit. And this study took basically this same cohort from this study and just followed them for a longer period of time. The dashed line at 30 months is when the ATTR ACT trial ended. And at this point, actually all of the patients were put on tafamidis. So the blue line were patients who were previously on placebo, who then were started on tafamidis. And you can see that the curves never, the patients who were originally on placebo never, so to speak, catch up with the patients who were started on tafamidis earlier. And so this is one of the arguments for starting tafamidis as soon as you diagnose cardiac amyloid in patients who it is appropriate. So adequate life, greater than 1 year life expectancy. And then it's also thought that patients with NYHA class 1 or 2 tend to have a greater effect from tafamidis compared to advanced stage disease. Or NYHA class 3 and 4. So to wrap up the second case, this is a 71-year-old man with biopsy confirmed wild type ATTR amyloidosis. He's continued on his treatment for smoldering myeloma, a concurrent diagnosis of cardiac sarcoidosis based on the path results is deemed pretty unlikely. And so his immunosuppression for sarcoid was not augmented. And then he was actually recently approved to start tafamidis for biopsy-confirmed ATTR cardiac amyloidosis. Any questions or comments on this case?
Thank you, Danee. These are really good cases. I'm just wondering, why do we think that after the first run of prednisone treatment, why did the inflammation go away? Did it actually have an effect on the physiology, or was it random, or, I don't know.
Yeah, I think that study that Dr. Smith brought up suggests that you can have positive FDG PET studies even without, I guess, biopsies showing active inflammation. And I don't know why that is. I don't know if for whatever reason ATTR amyloid can pick up or is just FDG avid. It seems like Dr. Dechek has maybe some answers.
Yeah, so I don't know whether Babak Nazar is on the call or not, but he had a paper not that long ago where he and others identified a population that had been diagnosed with isolated cardiac sarcoidosis. I think I have this right, but it turned out that they had a heritable cardiomyopathy, and that the reason that they had a positive FDG scan was thought to be because they had altered metabolism. So this is really a test for glucose uptake and utilization rather than a direct test of inflammation. It's interpreted as a test of inflammation, which it usually shows. But in the case of this group of patients, it was likely due to altered cardiac metabolism. So I give Babak credit for that explanation, not me, but it's an interesting one.
He more succinctly said exactly that in the chat, so that's exactly. And then Richard Chang added that that apparently Mayo has reported this also for AL amyloidosis, so it may not be something that's just unique to ATTR. It's just that I think it's maybe just a bias in sampling, and that he was saying that people with amyloidosis usually don't get FTD uptakes, and if you probably have a high suspicion of AL amyloidosis, you're probably even less likely to get that test. So yeah, so maybe there's some change in metabolism that's really causing it due to the amyloid, and it doesn't have to be ATTR necessarily.
Could you remind us why people with normal transthyretin get this disease?
I think it's just the propensity of the protein to form amyloid, so that the mutations can accelerate that, but the wild type does. I mean, but it's still, there's still a lot of mysteries in terms of why people get it and why it can become pathologic.
Dr. Smith, can I ask a technical question about the mass spec? Is it from one slide that you guys, there's enough tissue, or do you need multiple slides?
Well, we do triplicates just so we have, but we do a test. Each test is on one slide. We just do triplicates just to make sure that we're getting the same result 3 times.
It's really amazing because such a small area, right? As you showed.
Yeah. So right. You know, the more that's there, the easier it is. But yeah, it's pretty remarkable that you can type it with a fairly small amount of tissue.
Thank you. Okay, final case, case 3. So this is a patient who's 58 years old. He has non-ischemic cardiomyopathy, and he's ultimately referred to UW for end-stage heart failure and advanced therapy workup. His past medical history, he reports that in 1997, someone told him that he had, quote, a heart problem, but he doesn't remember more than that. He did well for the next 20 years. He describes a very active lifestyle without any cardiac limitation. But in 2017, this was the first time he was hospitalized for heart failure. At this time, he was noted to have an ejection fraction of 31% and also an LV thrombus. He had a cath done at this time, showing non-obstructive coronary disease. In 2020, he during the pandemic lost his job, lost access to medical insurance and his medications, and in that context was readmitted with an ejection fraction now of 20%. And then over the next couple of years, continued to have recurrent hospitalizations for heart failure and persistent NYHA class 2 to 3 symptoms. At the time he was referred to the University of Washington, he was on Lasix and pretty low doses of lisinopril, metoprolol, and spironolactone due to limitation of uptitration due to symptomatic hypotension. He had a family history that was notable for a half-sister that died at the age of 46, reportedly from heart failure. His father's side was unknown, and his mother was healthy. He was also an active smoker and currently working on trying to quit. This is his echo, and you can see that his left ventricle is barely moving. It's severely dilated, and the image on the right shows that we're sort of zoomed in at the left ventricular apex, and you can see that there's kind of an abnormal appearance of the myocardium. You can see that there's kind of deep recesses or trabeculations appreciated there. This is a sweep that the sonographer did through the left ventricle as well that I think highlights nicely kind of these deep trabeculations. And then on the right is a few still images from the cardiac MRI that he also had gotten that again confirms the highly trabeculated left ventricle. He had a non-compacted to compacted ratio of greater than 2.5 and diffuse late gadolinium enhancement in the thin epicardial layer. He's in and out of the hospital with heart failure. At some point, he also gets a cardiac monitor put on him for palpitations. And lo and behold, it shows that he's having multiple episodes of non-sustained VT, the longest episode lasting about 16 seconds, and then also multiple episodes of complete heart block. This prompts him an admission, and he subsequently gets an FDG PET to rule out sarcoid given the AV block and the VT. This study is negative for sarcoidosis. He goes and gets a single chamber ICD placed, and a couple weeks later is scheduled to receive a HeartMate 3 LVAD as a bridge to transplant. Over the next 2 years, he continues to have many admissions for heart failure, GI bleeds, driveline infections, but eventually undergoes successful cardiac transplant. Now we're going to look at his pathology.
Okay, I didn't have any good gross pictures for this patient's heart, so I'm going to show you an example of another case that has, at least by name, a similar pathology. And so here's a heart from a patient. You can see it's enlarged. There's dilated right and left ventricles, and then notably in the right ventricle, we typically see this prominent trabeculation. A lot of the shadows here obscure that, but in the left ventricle, the wall is usually smoother, and the papillary muscles sort of stick out a little bit. Here we see a lot of trabeculae present on the wall of the left ventricle, and then some sort of flattened papilla that sort of papillary muscle here that is attached to the mitral valve. The cross section here shows then again all of these trabeculae with deep recesses that occupy looks like a little over 1/2 of the thickness of the left ventricular wall. And so those are gross pathologic changes consistent with non-compaction. This just in contrast is a heart with hypertrophic cardiomyopathy, and so you can see there's not nearly the degree of prominent trabecula or deep recesses, and we have a markedly thickened septum and left ventricular wall. And here's another heart with left ventricular with hypertrophic cardiomyopathy. We see a marked thickening of the septum, and again, not a lot of the prominent trabeculae as I showed in the first heart.
Is the pink scar, sorry.
Go ahead.
Is the pink stuff?
No, so this is a heart that's been fixed, but it hasn't been completely fixed. So the fixed part of the muscle is brown, and then the stuff where the formalin hasn't penetrated is still pink. So that's all that is. So here's some of the sections from this patient's left ventricle, and you can see that there's some, we can see some of the trabecula here and maybe a few little channels here, but then here's another piece here. We have epicardium, and then we have some of the muscle here, and then here deep, right adjacent to the epicardium, we're seeing these channels in the trabeculation. So a fairly prominent trabeculation was most notably in the apex of the left ventricle, as was shown with imaging. And we look at higher magnification. Here's these channels, really abnormal morphologic appearance for a left ventricle. This should just be solid muscle. So this is a very unusual finding. But then if we look in here too, we see some of this lighter pink material in amongst the red cardiomyocytes. And so at higher magnification, we see this patchy interstitial and periocellular fibrosis, and then there's also some cardiomyocyte hypertrophy that we'll look at higher power. So you can see these hypertrophic cardiomyocytes, which are probably adaptive changes to the loss of cardiomyocytes that's sort of happening throughout the myocardium. And this is just sort of happening sort of piecemeal. And this is in contrast to an ischemic type of injury where you have the subendocardial loss of myocardium that eventually gets replaced by fibrous connective tissue. This is just sort of sprinkled throughout the myocardium. Oftentimes it's even seen, as in this case, more prominent in the epicardial half of the myocardium. When I see that pattern, I think of just sort of this is likely due to an intrinsic cardiomyocyte defect. That's something's wrong with that cardiomyocytes, leading to its loss, death, and then replacement with with connective tissue, and that just sort of happens, sporadically or somewhat randomly, probably not completely randomly throughout the myocardium. And then here's a higher magnification, just showing you what this looks like at high power. And you can see that these cardiomyocytes have these lipofuscin granules that are present, and those are the indigestible pigments that we see within lysosomes that just accumulate with age. Well, when a cardiomyocyte dies, a macrophage comes and eats it, and here's what we see is this macrophage that just has its cytoplasm filled with the lipofuscin pigment because it eats up all the cardiomyocyte and digests everything, but it still can't digest that lipofuscin, so it still hangs out there. So this is a good example of that there was probably a cardiomyocyte there at one time, and now it's been eaten, and all that's left of it is the lipofuscin to look at. Just looking at the arteries, as you would expect, there was just some eccentric atherosclerosis, but no significant change. So the diagnosis was a non-ischemic cardiomyopathy. The pathologic changes were most consistent with non-compaction, and so he has this non-compaction type of cardiomyopathy with also hypertrophic features, and importantly, there's no evidence of sarcoidosis. So when we say non-compaction, I think there's always a little bit of a difference between what a clinician calls something and what a pathologist calls something. So I think, when we say something, you should say, well, it could be a distinct cardiomyopathy. We could be talking the same language, but it also could be a congenital trait that could have different implications. It also could be an acquired trait that's shared by other phenotypically distinct cardiomyopathies. So, when you look at things, we can see changes, and we'll call it that, but, proving the etiology, I think, takes a little bit more correlation with other types of data, other clinical data, and other type of laboratory data. Importantly, you see this type of change, the non-ischemic cardiomyopathy, those changes that are consistent with non-compaction, you should think about genetic testing.
Okay. So I just want to highlight that this is sort of my synthesis of LV non-compaction. I think that this is a very confusing topic that's very controversial. The AHA, for example, considers LV non-compaction its own primary genetic cardiomyopathy, whereas the ESC currently classifies LV non-compaction as unclassified cardiomyopathy. So I think we're still, as a community, trying to figure out what the best way to classify LV non-compaction is. I think one thing I wanted to highlight is that LV non-compaction or hypertrabeculation, it goes by a couple of different names, but that's really an imaging finding that can be seen in individuals where it's a normal variant or it's actually acquired and in some cases reversible. And thought to be due to more of a physiologic adaptation. So patients who are elite athletes or patients who are pregnant, for example, may develop this kind of more hypertrabeculated appearance. However, LV non-compaction is also seen in real pathology, and there are patients who present with arrhythmias and pretty significant cardiomyopathies, as we saw in our patient's case. And so I think this is just really nuanced, but you want to try and figure out how can we avoid overdiagnosing people who actually don't have truly, like LV non-compaction and risk of progressing over time, and how do you avoid missing the diagnosis in patients who either have evidence of cardiomyopathy or are at high risk of developing it in the future. What makes this disease process further challenging to study is the fact that there's no current consensus on imaging criteria. So both for echo and for MRI, there is not a consensus on which criteria we should use. This is just a slide showing that the three probably most popular echo criteria for LV non-compaction, and you can see that they're all very different. They're measuring at different parts of the heart, different phases of the cardiac cycle, and they have different cutoffs for what's considered normal or abnormal. And actually in the same cohort of patients, each of these criteria will give you different prevalence of LV non-compaction, which makes it hard to study when you're comparing different patient populations. And then the point that if you use imaging in isolation, this is going to lead to overdiagnosis. And so, as Dr. Smith mentioned, you really have to consider, in addition to the LV non-compaction seen on imaging, you have to go a couple steps farther and consider the symptoms that the patient's presenting with, other morphology features as seen on echo or cardiac MRI, and really the one with the star, family history and genetic testing. So if you have a patient who's coming in and this is an incidental finding, they're asymptomatic, the rest of their echo is totally normal and they don't have any family history, well, this patient probably is in the benign category where this is just a variant or some kind of acquired phenotype. Whereas if you have a patient who got the echo because they're having heart failure, they have evidence of cardiomyopathy, and they have say a family history of heart disease or heart failure in their family, you're going to think that this is more likely truly non-compaction cardiomyopathy. I think in reality, patients are often a blur between these two categories, and so it can be really hard to distinguish pathology from normal variation. But an important thing that I was reading is the family history and genetic testing really should be prioritized and to have heavier weight than the clinical or imaging features. And so oftentimes, if you're not sure if someone is presenting with kind of the benign form of LV non-compaction, you can take a thorough family history, and if it seems concerning, actually send genetic testing to see if they might have some kind of variant that makes them higher risk for developing major cardiac events in the future. This condition is also confusing in the sense that there's a lot of phenotypic overlap with other types of cardiomyopathy. So while you can have isolated LV non-compaction and cardiomyopathy from that, there are many more patients who I think have kind of a combination of a dilated cardiomyopathy phenotype with also features of LV non-compaction. Similarly, you can see this with hypertrophic cardiomyopathy or restrictive cardiomyopathy. And again, this is why the ESC, I think, is not sure whether or not to classify this as more of a phenotype or a variant seen within other primary cardiomyopathies or truly its own distinct entity. As I mentioned, genetic testing still needs to be studied. I think this is we're just scratching the surface so far, but this was an interesting study that looked at 200 plus patients from about 113 different families, and they separated patients based on their phenotype. And so in patients who had primarily isolated LV non-compaction, these patients tended to have mutations in the head of the myosin heavy chain. And clinically, when they followed these patients forward, they tended to have a more mild clinical course. Whereas patients with the more dilated and kind of mixed LV non-compaction phenotype, these patients tended to have mutations in the tail of the myosin heavy chain. And these patients were much more likely to develop or present with systolic dysfunction, and they had increased MACE. And then lastly, the hypertrophic cardiomyopathy LV non-compaction phenotype was rarer in this cohort. This was correlated with genes, particularly in the myosin binding protein. And they were, because this group was so small, all they could say was that there seemed to be a higher incidence of hypertension. In terms of management for LV non-compaction, as I mentioned, I think genetic counseling and then often proceeding to genetic testing is a really important component in trying to prognosticate these patients. You treat their heart failure according to standard guidelines, kind of irrespective of LV non-compaction. For example, if you have someone with hypertrophic cardiomyopathy with LV non-compaction, you would just treat that patient like a hypertrophic cardiomyopathy patient. Because they're thought to have a higher risk of arrhythmias, some people will do like an annual ambulatory monitor. I don't think that there's good evidence for that, but you should have in the back of your mind know that you should be monitoring for the presence of arrhythmias. These patients should be considered for advanced therapies such as VADs and transplants in end-stage heart failure. And then the only difference or like specific management for these LV non-compaction patients are to maybe consider anticoagulation in patients who have LVEFs less than 40% and or atrial fibrillation irrespective of the CHA2DS2-VASc score. And that's just thought to be because if people have systolic dysfunction inside all of those like deep trabeculations and recesses, it's thought that maybe you could develop mural thrombus more easily. So to conclude this third patient's case, he's a 58-year-old man with features of LV non-compaction cardiomyopathy, now status post-cardiac transplant. Interestingly, following transplant, he was enrolled in a study that did some genetic testing for cardiomyopathies, and he actually has a pathologic mutation in the myosin binding protein that was, quote, definitive for HCM. This gene, as I showed in one of the prior tables, is also known to be associated with LV non-compaction. And when I did some digging way back, I was able to find his echo report from 1997. And at that time, his heart was consistent more with a hypertrophic phenotype. His septum measured 2.6. He had a narrowed outflow tract. And he was told, you need to follow up with cardiology, but was unfortunately lost to follow up. So never saw anyone until he presented 20 years later with heart failure. It's kind of interesting. I asked Dr. Owens about this, but wondering if people can sort of morph phenotypes over time. And he was saying that in a few hypertrophic patients, their myocardium can over time get replaced by fibrosis, and they can actually look more like a dilated phenotype over time. And so I think that may have been what happened with this patient, where maybe 20 years ago he looked more hypertrophic, and now he very much looks dilated with more prominent LV trabeculations. So he's currently awaiting a formal referral to genetics, but this is important, less so for him, but more important for his family members. All right, questions or comments on this last case? Perfect. All right, we have 4 minutes in case there are any questions or comments. Thank you for your attention.